I'm up there, but just let me know and we can, just stop me or whatever. I'm happy to, throw your hand up, or Sohail or someone if wants to just facilitate, let me know. I'm just looking at everyone here. So we have pediatrics, critical care in Ghana. Awesome. CICU hospitalist, Pete's resident. Great. Okay. Awesome. Well, all right, let's get started. And I also have multiple screens. So if you see me looking in different places, that's because I have things pulled up on different screens, but all right. All right, I have no disclosures. I did want to say this work was funded by a couple of grants that we were lucky to get, including one from the Hellman Foundation and one from the Doris Duke Charitable Fund. So I just want to give you kind of a bit of an outline of where we're going to go with this talk. So start with some background. I'm going to talk about sort of the state of emergency care training, specifically pediatric emergency care training and education in Africa. We'll talk a little bit about AFEM, like I mentioned. I want to talk to you a little bit about the project, like when you think about curriculum development for medical education, specifically in low resource settings. I'll show you what our timeline looked like. I'm going to talk a little bit about kind of what our process looked like so you could see what we did and what we came up with. And then I want to talk a little bit about reflections and next steps, because I think that's really important when you get sort of started with a project and you kind of get really embedded in it. And then sometimes it helps, to take a step back every now and then and kind of see where you are and think about where you want to go with everything and how to best get there. And then I want to spend a little time talking about partnerships. And because, as I mentioned, this project was really, it was a partnership from the very beginning. And I think talking about partnerships in global health is really important to think about some of the components that can set you up for success. And then finally, I was going to offer just a couple of my humble thoughts about building my career in global health and sort of where it's gone and sort of how I got there. All right. So launching right in, so as you guys will recognize, is the map of the continent of Africa. And as you can see, this is pulled from an older article, but there's really the colors that you see highlighted here. These are the places that have formal emergency medicine training programs, and there's not that many. Mozambique did add one, by the way, since this map was created. There are no dedicated pediatric emergency medicine sort of fellowship-like or training programs currently being offered, with the exception of there is one in Kenya. It's sort of a combined PEM and critical care training program in Kenya. So that is going on currently, but that's sort of unique in its kind. And then why this is really important is because, as you can see, from this population pyramid, the current population of sub-Saharan Africa is really skewed towards a younger population. So children or those under the age of 18 years are going to make up a larger part of the ill and injured than you're going to be seeing when you practice, say, in the US or other high resource settings. Secondly, for those of you who know Terry Reynolds, who have worked in the World Health Organization with some of their emergency care efforts, they've done a really nice job of showing that timely and efficient emergency care has been identified as an important factor contributing to improved survival rates for critically ill kids in low resource settings. And I think we can estimate that children comprise at least 30% of urgent care and emergency care sort of visits in sub-Saharan Africa, and that child mortality is highest in children less than 5 years. Which you will hear a little bit more from Dr. Raj Daftari, who'll be talking a little bit about that. All right, so let's talk a little bit about AFEM. So AFEM is the African Federation for Emergency Medicine. It's a really large professional organization comprised of over 2,000 practitioners of emergency care across the African continent. I think when it was practicing Ghana, maybe you would know about this, supports the development and advancement of emergency care in Africa through several different lenses: leadership development, advocacy, collaboration, research, education and training, and then also offering up policies and frameworks. This photo here that you see is taken in Tanzania at Muhimbili National Hospital, which is the National Referral Hospital in Dar es Salaam. This is the first class of emergency medicine residents that were trained there. So the members of AFEM had expressed a need for sort of a more pediatric focused emergency medicine curriculum to help with the care of a lot of the children that they were seeing. AFEM does have, if you've ever seen their website, they have a lot of educational resources available, and they do have like emergency medicine curricula that a lot of countries have used to base, like say if they're starting a new residency or something, they've used that to base off of, but there was nothing really pediatric focused. And so that was kind of the request. And so the leadership of AFEM kind of convened this multi-institutional group of both PEM and then, obviously PEM doesn't exist in a lot of places. So sort of just experts, people who take care of a lot of sick children to sort of develop this curriculum. And UCSF was one of the people who were involved, and I was helping to sort of lead as the leading institution on this. All right, so talking a little bit more about the AFEM partnership, and we're going to, like I said, we're going to talk about partnerships more later on in general. But it's really important to think about how you set up your partnerships and making sure that you have your partnerships in place too. There's so many reasons why this is critical, not the least of which, right, is the humility to recognize that oftentimes if you're not in a setting, like living there and working there, you may not truly understand all the challenges of those that's happening. And so, but thankfully, your partners who are there do. So being able to address identified needs in a way that makes sense for them is really the only way to ensure that that you have a really successful partnership and a really successful project. So that's why just wanted to point this out here to say that's why it was so important that this request came from the AFEM members themselves, saying that this is something that we really need, and then activating this group to sort of respond to that. Sometimes requests come in the other direction. And so, and not to say those aren't necessarily okay as well, or there's anything wrong with those, but I think having it come from the people who want it oftentimes can help you avert some challenges. And we'll talk a little bit more about partnerships later. All right, so here's a little bit, we're going to start into sort of the medical education and curriculum development piece here. So we modeled our curriculum development when we said, okay, we're going to develop this pediatric curriculum. And this is a really super well-known method by Patricia Thomas and David Kern. There's a book out there, Curriculum Development for Medical Education. It's sort of the 6-step process, as you can see here. I'm not going to get in a lot of detail about this because Dr. Nick Glom, who you're going to hear from next about developing an EMS curriculum in Botswana, is going to talk about this in more detail, but I just wanted you to see it, to know that this is kind of the process that we used. And then the other thing to think about in the context of how we developed our curriculum is seeing that recognizing that providers across the African continent are really variable, right? I mean, it's a various group that are all caring for children, different settings, different set of resources, different clinical experiences. Not all physicians, not all nurses. It's sort of a mix of people. So we recognize that creating one curriculum for everyone may not necessarily, not one size fits all. So thinking about creating 3 different tiers of providers for which we could sort of create this sort of sequential curriculum for to be able to address meet people where they are in terms of their training and their needs. So you can see here, tier 1 being sort of your nurses, and these could be, and oftentimes your junior nurses or your pre-hospital providers. Tier 2 being your, depending on where you're working with, they're called medical officers, and oftentimes your senior nurses will fall into these group. And then tier 3, tier 2 sometimes has your residents depending on your specialty, and then tier 3 would be even more people who are even further along in their training. So here's the timeline for a project. It's a lot going on, but I wanted to highlight a couple things. One, notice this has been going on for a while, right? So we started back in March 2017. So this has been going on for over 4 years. So these things can take a while. I mean, granted, this was a very large project we took on, but just to keep in mind that these are not the kinds of things where you're like, gosh, I need a project for like a year and this is like going to happen. Definitely little pieces of that could happen in a year, but it takes a while. Granted, 18 months of that was COVID. So, but just sort of highlighting the steps, and again, following along with Kern's model. So starting out with the needs assessment at the very beginning, we did this across 2 hospitals in Dar es Salaam in Tanzania. And then kind of developing your learning objectives based on your needs assessment, creating and refining your learning objectives, which we did at AFSEM, which is the African Conference for Emergency Medicine, and that was held in Kigali in November of 2018. And then once you have your learning objectives, really developing your curriculum, right? So we first started, makes sense, developing the Tier 1 curriculum. And then our second priority was developing the Tier 2 curriculum. And then keeping in mind when you develop your curriculum is thinking about how are you going to evaluate your curriculum. And as you can see, we did pilot them in 2 different places, but you also need evaluation tools. So that was another thing we had to create along with the curriculum, or these evaluation tools. As you can see, our first pilot implementation and evaluation of the Tier 1 curriculum was again in Dar es Salaam. And as you see, we had a very strong partner there, which was part of the reason we were able to do this with them. And then later in that same year in 2019, we piloted in a different site in Monrovia in Liberia at JFK Hospital with another partner. And then finally, once you pilot it, so we took it through a peer review process. So all the people who had originally contributed as authors were assigned different modules to review. And then finally, we did an expert review through AFEM leadership and identified members. And then the Tier 1 curriculum was released on the AFEM website in late 2020. The Tier 2 curriculum is currently it just completed peer review and is currently undergoing expert review now. So just to give you an idea of sort of like how this could look. All right, and then let's talk about the steps in a little bit more detail. Like I said, I don't want to go too far down the hole, but just so you guys can see what we found. So for the needs assessment, what we were really focusing on is, what do you want to teach, right? How do you want to teach it? And then what about, and I think also you need to think about what is the setting you're teaching it in, right? Like what do people think about the challenges that they face caring for kids in these settings, right? So I think those are 3 big categories you want to think about. And then also so when you think about the format that we used, we kind of tried to take this from what we call a mixed method standpoint, where we tried to look at it both quantitatively. So like, one of the benefits of doing this in DAR was that Muhimbili, the emergency department there, has an electronic medical record system, not common, but we were able to take a year's worth of diagnoses from there and sort of analyze them and look at what are kids coming into the ER with. And then we were also we were able to do interviews and focus groups of providers working there, from different like nurses and PAs and registrars and residents and attendings, and looking at what really are the things that people are facing. And what we were able to find is really interesting. So on the left, you see here what we got from interviews. And then on the right is what we got from the emergency department records. And like 8 out of your 15 top diagnoses were actually the same. So what people were thinking they were actually seeing and needing to learn more about is actually what they were seeing and learn more about. So that was kind of cool. And don't worry about the details here. I was just sort of wanting to show you that it was nice to see the correlation. And then here, these are some of the themes that came out of the interviews that we did, asking people what are the challenges that they're facing when they are taking care of these really sick and injured children. So things like delayed presentation to care for all these various reasons. Complications with care that they receive in the emergency department because of, for instance, lack of pediatric specific supplies and equipment. And then finally, what happens in terms of why they think some poor outcomes could be due to like some challenges faced in the inpatient setting. All right. So again, don't worry about reading these, just wanted to kind of show you some of the general themes. All right, so So the next process, just to kind of give you an idea of how we ended up carrying this out, was developing our learning objectives. So what we did was we had a bunch of learning objectives, right, that were taken out of this needs assessment that we did. And then we needed to review it with people to figure out, is this really what we should be targeting our curriculum at? So the way we did that is using a modified Delphi format. And for those of you who are interested, who are familiar with this process, basically, it's like this groups and consensus technique. You are presenting, you have like a group of experts who, like I said, we did this at the APSEM conference in Kigali. So it's all of these emergency medicine people who are working or caring for kids, critically ill and injured kids in mostly sub-Saharan Africa, but you get everyone around the table, you put up all these different learning objectives, and you have people vote on whether these should be included or not. 70% gets you an automatic inclusion. Under 30% means it brings up a discussion. And so people try to discuss the benefits and cons of leaving this learning objective in, and it can get revoted on once. And if it doesn't make it again, it gets pulled out. And the voting is all anonymous to kind of help people feel like they can have sort of a more balanced input. So these are, just so you know, almost like most of the objectives made it through or got edited in some form to make it through. And so as you can see here, tier 1 obviously has fewer learning objectives, tier 2 has more, and then tier 3 has the most. All right, and just to give you an example of what a learning objective looks like and how it looks a little different for, say, a tier 1 provider, a tier 2 provider, and a tier 3 provider, I've sort of put this up here. Excuse me. So a tier 1 provider would be like recognizing different etiologies and management for altered mental status in a child, and then importantly, recognizing the indications for transfer. Assuming that a tier 1 provider doesn't necessarily have a lot of making the distinction between the provider versus the resources there. And then tier 2, it'd be a little bit more advanced. We want you to understand the etiologies for and really start the management. And then tier 3 is really talking about specific, very specific etiologies of altered mental status in a child and really being able to describe them. And manage the most emergent complications. For instance, increased intracranial pressure. I'm just going to mute real quick. Okay. All right. So let's talk about the tier 1 pilot implementation. And as I mentioned, this was held in Dar es Salaam in Tanzania. But before I do, does anyone have any questions? Comments? Like I said, I can't really see the chat, so I just want to. No? Okay. All right. So we conducted the training over 2.5 days. We had about 15 nurses participate, and they were matched to controls. And the things that we used would be lectures, skill stations, and simulation scenarios. And then for evaluation and feedback, this is kind of how we evaluated our curriculum. We looked at self-efficacy surveys, pre and post. We looked at knowledge tests, pre and post. And we also created these critical action checklists for things that we felt like were important for providers to be able to do. And we would actually observe them during real life resuscitations, and we would have our data collectors observe and sort of check off if these critical actions were being performed. Unfortunately, we were only able to do them post due to some delays with getting IRB approval locally. And then finally, we did sort of informal interviews of participants just to find out sort of, what their experiences were and what we could improve. So just to give you guys an idea, I wanted to show you the schedule for the training so that you can see, some people were asking, oh, so what did it look like? What did you guys do? So this is kind of the 2 days that I've talked about. You can see here, you have like different modules set for different times, breaks set up for meals and just breaks in general, and then review and questions at the end. So nothing too out of the ordinary here, but that's sort of how it was set up. And again, I think, your start times and your end times, another good thing to talk to your partners about what's kind of acceptable in your situation. And then here's some photos just showing you guys some of the, so here in the bottom right corner, you can see this was, we had this room, it was sort of their lecture room to use. And we had, so here we were able to provide lectures using PowerPoint slides. This is Kilalo Mjema, who's one of our emergency medicine attending. She was one of the lead instructors on the course. And then during the simulated scenarios, these, as you can see, the mannequins and stuff we actually brought with us. They were purchased with grant funding from the grants that I had mentioned. And then, yeah, so we were able to purchase them for the hospital and for the program so that they could continue to use these to train after we'd left. And then here a few more photos showing some of we broke people up into small groups and had them practice the different skills themselves with our nurses. You can see here. And then as you see, so there's a couple of residents who came along with me. So here you see Alex Werney. I think Holly Vo also came with me, and they're ex-pediatric residents who graduated from the program who are working with me on the project at this time. Okay, so let's talk a little bit about the evaluation. So I'm not going to go into this in too much detail. I mentioned already the surveys, the knowledge tests. We use critical action checklists. And so these are based on Kirkpatrick's level evaluation of training. You'll see this if you're in medical education quite a bit as a way to, it's like sort of levels that you evaluate your training on. So one is participants' reaction, which we use the surveys. One is learning, which is sort of using knowledge tests, and then behavior. We were trying to evaluate, do participants' behavior really change after we delivered this curriculum training? And that's where we got the checklists from. And then looking for longer term results, we really tried to target 48-hour mortality, but unfortunately we weren't able to collect that data. Well, what happened was because of IRB delays, we weren't able to collect the pre. And so therefore the post was, we didn't have a point of comparison to make it useful to compare for the post. We did use a non-randomized control design for this study. So we were able to compare pre and post both within and across groups. So just to, I'm just giving you the summary of the results. I'm not going to make you sit through the graphs, but basically, so self-efficacy surveys. We asked people, all right, how comfortable are you doing these pediatric resuscitation skills before the training? And then how comfortable are you after? And then, like I said, we had our intervention and a control. So we compared across the same, we compared people to themselves and to the controls. And what we found was, people felt more confident after the training performing these skills. So that's good. Knowledge tests, did they actually gain any knowledge from the training? We found that there was a significant improvement. They did gain knowledge after the training. Critical action checklists. So when we actually watched them observe them perform resuscitations in kids before and after, we didn't have the before, we only the after. So we compared participants to controls. There was actually no difference. There was a couple that we saw significant difference on, but actually we didn't see a difference between those who got trained and those who didn't. And then, like I said, 48-hour mortality, we weren't really able to collect this data. So I wanted to give you an example. This is just an excerpt of one of the critical action checklists that we used. So we picked 3 most common scenarios, and one was pediatric respiratory distress. So here's just an excerpt of a checklist. It's a binary checklist, so yes or no. The data collectors were trained to either say yes, they performed it, or no, they did not perform the action. And as you can see here, I won't read it to you, but here's what sort of the critical actions that we identified for a nurse responding to a child in respiratory distress. So I wanted to kind of crowdsource here. What do you guys think? Like, why do you think, seeing this is just a small excerpt as an example, why do you think we didn't see a difference between those who participated in the training and those who did it in terms of performing these behaviors? Any thoughts? No other thoughts? Well, a couple things we considered were, one is that, like, for example, number one is stating the child is in respiratory distress. So that's kind of like a proxy for recognizing an emergency condition. But, these are real resuscitations. So, I mean, do we really expect a nurse to be like, this child is in respiratory distress? Maybe, maybe not, right? Like maybe they know that in their mind. They're not necessarily saying it out loud, or maybe they're writing it in the chart, but not necessarily saying it out loud. So that could be a reason why we didn't necessarily see a change there. Maybe they're not always verbalizing it. And another thing we thought about was, maybe we did this right after the training. So maybe people need some time to actually practice it and do it on a daily basis before we're actually going to see any significant change. So that could be another reason as well. But if you guys think about this later and you think of any other reasons, do let me know. We're really interested. We've been sort of mulling this over in our minds for a bit. All right, and so finally finishing up our work in Tanzania. So we did return 12 months later in March of 2020 to do sort of a 12-month follow-up. And really our question there was, so what happened, right? A year later, we came in, we did this training, we collected this data, and then, the program sort of took, we sort of helped them set up some sort of a training schedule or create, we had all these simulation scenarios and things for them to use going forward. And then a year later, now what? So we went in and we collected data. So using our original measurement tools, the surveys, the knowledge test, and we used only the original participants and controls, which we did lose some. And then after that, we did offer a refresher training to the entire emergency department. So all the nurses who worked in the emergency department could participate in this refresher training, which is what is a photo that you see here. So what did we find? So in terms of self-efficacy, so people their confidence in being able to perform these skills did go down. I guess not surprising, right? Compared to when we left, but it didn't go all the way down to before we even got there in the first place. So it didn't go down to pre-pilot training levels. So there was some confidence, I think, maintained. And then interestingly, knowledge did not change at all. So there was no significant difference when we compared their knowledge scores when we came back a year later to when we left at the time, the post-pilot levels. So this really brought up the question, is 12 months an acceptable interval for refresher trainings? It seems long, right? Like a whole year, but I think it really just depends on what's happening in between, right? Like are people, and people were receiving some interval trainings in between. So it's something that we're still sort of mulling over as well. But another thing to think about is really thinking about, okay, I've done this, I've implemented this curriculum, but what are sort of the long-term consequences? So finally, where are we with the tier 1? So it was published on the website, like I mentioned, in AFEM in 2020. There was a manuscript that was published in the Western Journal of Emergency Medicine sort of describing the pilot. And then there's also going to be a manuscript describing sort of the 12-month follow-up process. And as you can see here, this is the team that trained and all the nurses here who were trained in the process. Okay, now let's talk a little bit about tier 2. So this will be quick because it was very similar to tier 1. It was just held at JFK, so John F. Kennedy Memorial Medical Center in Monrovia. In this case, we did use obviously a tier 2 group of providers, which were identified by the Ministry of Health as 36 interns and residents. We were not able to recruit any controls, and that was just a limitation based on the local IRB's recommendations, which is fine. And then similar format to exactly how we did it in Tanzania, but with a different group and obviously a different setting. So you can see here, this is the group that participated. And we did bring with us mannequins as well, but unfortunately we had some difficulties getting them in. So we actually used our own participants to be our simulation subjects. So all this, what you see here is these simulated scenarios where we had the teams actually trying to treat and stabilize each other in different scenarios. And then here that we had, this is just sort of classroom work that we had for them doing at the time. All right, so what did we see? So again, improved confidence, improved knowledge, but critical actions, we didn't see a lot of significant changes either when we compared people to themselves pre and post, because we didn't have a control group here. So same discussion, same kind of questions around why didn't we see that sort of difference in result? And a lot of it is stuff that we're working with the local institutions on. But like I said, if you guys have any other ideas, please let me know. Ongoing discussion. All right, so next step was, okay, now let's stop and let's reflect. This is often helpful in these long drawn out projects where you're sort of going from one step to another. And like I said, you're following the 6-step model by Kearns. It helps to stop and reflect. Okay, where have we been? What have we done? How does this match with what we originally were going to do? And then also, what lessons have we learned, and where do we want to go now? So there were a few big conclusions that we came to. One is that we recognized that most of the healthcare workers that we were targeting, those caring for critically ill and injured kids, would fall into the tier 1 and tier 2 categories. They're, like I mentioned, there's few subspecialty training programs that go to the level of necessarily a fellowship. And so, at least in PEM, that in pediatrics or in emergency care. So there were very few tier 3 providers existing. And so we decided not to pursue developing a tier 3 curriculum. So it's just going to be a tier 1 and a tier 2. And we felt like that would hit most of the providers across the continent. So instead, we felt like, due to those findings we'd already talked about, why we're seeing increase in knowledge and confidence, but maybe not in actual behavior, maybe we need to take a little bit closer look at this piece, right? Was it due to how we taught it? Did we have a good understanding of what teaching methods are most effective in a lot of these settings, especially low resource settings? And then kind of what role do we have to play in terms of the curriculum development, implementation, and dissemination? How can we be a better partner in this process? So what we decided to do was kind of conduct what we called an implementation study, looking at trying to get a better understanding of like, what are the best teaching methods and why, and what are the parts where we can really make the most difference for our local partners. So we designed it to sort of conduct interviews with healthcare workers across the continent in different regions who were caring for these kids. And we had sort of a whole sort of interview guide set up of questions to ask them that were targeted at sort of the questions that I've already mentioned. So the idea was to conduct this at AFSEM 2020, which was going to be held in Mombasa in Kenya. And after we had recruited a core group of trained interviewers from AFEM itself. However, like many things at that time, our efforts were delayed by COVID-19. So we've had to take a lot of this virtual and offline, but to date, we've recruited almost 13 interviewers mostly from East Africa, a couple from Central, and then, so I say a majority from South Africa area, some from Western. And we've obtained both IRB approval and a little bit of grant funding to be able to compensate our interviewers, right, for their time in terms of training and as well as conducting the interviews. And then we're hoping to be able to, and we've also created the interview guide. We're hoping to launch that right now, actually, as things kind of open up a little bit. So more to come. So that's kind of where we are with this whole sort of curriculum development process. Any questions on that before I move forward? Oh, I see a comment in the chat. Okay. One thought, had the local participants been involved in SIMS before, perhaps the format was new? Yes, thank you, Lynn. I totally agree. I think in this particular case, the nurses had done SIM before. at least in Tanzania. In Liberia, they had done some sim, not as much. So perhaps that could have played but yes, the format is definitely, I agree, something that we've been really trying to take a really close eye on. Anik Patel, that was my thought as well. Yep, in Rwanda, a lot of residents were really nervous performing simulations in front of others and peers. Language barriers, yes. Yep, and you've seen this in India and Sudan as well. Yeah, for sure. Yeah, and definitely with how it was taught, that's definitely something to think about. And power dynamics too, right? I think you have to think about when you ask people to perform in this way in sim, right? Like who's there, and thinking about like interdisciplinary sometimes can be very challenging in certain settings. And so really trying to keep in mind what people are comfortable with and what they're not is important as well. Was there any thought about doing virtual refreshers from afar? Yes, we did have that discussion. I think, and sorry, I didn't mean to put you on the spot, but do you mean like in before that we did the 12-month one in person, or?
Yeah, hey Carol, this is Anik. Yeah, I know exactly. I was just wondering, especially with COVID, I can't remember the timeline, but just doing virtual, like intermittent kind of refreshers, because you're right, the 12-month period does seem like a long time, even for like Americans who are used to simulations, to remember how to do certain things. So yeah, that was my question.
Yeah, no, absolutely. Yes, that is a really good question. We did. Fortunately, the refresher that we did was in Tanzania. That was all related to the tier 1 pilot, and because we were fortunate enough that our partners, which I'm going to talk more about here, is they are very they've had an emergency medicine residency program for a while, so they were actually they've got a lot of teaching faculty there, and so they were able to take a lot of the supplies and the teaching materials that we left behind and sort of do refresher trainings during that 1-year period. And I think that is probably why we saw such good numbers when we showed up a year later. Me from San Francisco, and I think I had a resident that had joined me from Arizona. But I think it's because our partners at Muhimbili had been sort of doing this along the way. But I think if you don't have that sort of partnership, I think virtual refreshers are definitely a good option. I think bandwidth sometimes gets in the way of that, depending on how good the bandwidth is wherever it is that you're trying to get it. But I think or even recording videos could be another idea. I think, I think, Anik, that's a really good thought. And as COVID continues, a good thought thinking going forward as well. Okay. Great. Any other questions or thoughts, comments?
Hey, Carol, this is Sohail. I was curious, who led the sim sessions? Who on the ground were the folks actually moderating and facilitating?
Yeah, so it's a good question. So they were moderated by, so most of the lectures were given by Kilalo and Gemma, who I showed you. The sessions were Kilalo, where the facilitators for sim were Kilalo, Pendo, who is the picture you see on the screen now, and Raya, who's one of the emergency medicine residents in the program at Muhimbili. Yes, and then Holly and Alex, who are with me from UCSF, I paired them with one of those three. And Kat was the other one. We had a fellow with us. So Kat, Raya, Pendo, and Kilalo were the 4 main, and then I paired myself with one of them, and then paired Alex and Holly with one of them. And that was actually really helpful because oftentimes oftentimes the language too, they could go back and forth depending on English and depending on in Swahili, depending on what people were comfortable with. So that was helpful too.
I had a question as well. Hi, my name's Maron.
Hi.
I was wondering if implementing it earlier on in like the learning process. So if I'm like a first year resident or a first year nursing student, that way, like when you're coming back every year, it's like, I wonder if that would change like your critical check, like using that checklist and having it earlier on. Just because if you've maybe been in nursing for a while and maybe it's hard to kind of switch and change.
Yeah, actually, that is a really good thought. And we had not really even thought about, I mean, we did take a look at the demographics of the group, like for instance, the nurses and you know, in Liberia, we knew where everyone, because it was only the interns and the residents who were participating, but the nurses were all relatively experienced nurses. So I wonder if that did definitely have a role to play in Tanzania in terms of them being able to change their behaviors or even wanting to change their behavior. So, but yeah, that is a really good thought. And I think in the future, that is definitely something I'll keep in mind in terms of like looking at, you know, where we can make these things happen. Yeah. Thank you.
Another question I had, Carol, sorry, I have like a million questions for you.
Yeah.
Was there a sense of kind of figuring out what they were doing prior to the educational modules? Like, so for instance, when I was in Rwanda, we did neonatal resuscitation simulations, and we did helping babies breathe and that sort of thing. But then we realized that before helping babies breathe, they had these sort of habits, some of these nurses, of doing certain things. And we didn't know that till afterwards, that like, oh, like this is actually what they were doing. And I wish I knew this so I could have taught them differently, or anything like a baseline prior to the teaching.
Yeah, no, that's a really good question. I do think it was not a formal evaluation, and I do think that probably would have been helpful for sure. But we did sit down with our nursing partners, and they're sort of like charge nurses there, and kind of, you know, we showed them obviously the curriculum and talked through everything just to make sure that it looked, that it was appropriate and relevant to their scenario too, right? Because I think not only every country and every city and every hospital is a little different too, right? Like, you know, we didn't want to be telling them to do certain things if they didn't have certain things, or, you know, things like that. So we did sort of show them that and talk through, does this make sense? Do we need to change anything? And does this, so I think that was an opportunity for them to speak up about maybe, you know, this is what they're actually doing, but it is important to note that you're right. It is not, we didn't specifically ask for that. So I think it is a good idea to formally ask for, you know, what are people doing right now? For sure. These are great. I'm gonna write these down too while we're talking. Any other questions? Anika, I think you said you had other questions.
No, I think I'm good right now. I'm sure I'll have more.
Yeah. Okay. All right. Okay, cool. All right. So I wanted to spend a little time, like I said, Nick is going to talk to you next about, he's going to go into a little more into the weeds on the curriculum development process. But I wanted to take a little bit of a diversion and talk about a little something different. Wanted something that's near and dear to my heart is partnerships. And then, like I said, I was going to talk a little bit, just a few thoughts on my own sort of in global health careers. So for the partnerships, you know, we've already sort of talked about the partnership that we sort of developed, that AFEM, you know, is the partner, is our, you know, and then working with all of these institutions who are involved with AFEM. And that's kind of how we got our sites, right? In Dar es Salaam and in Monrovia, is through groups that were already involved in AFEM and sort of working with them. And so I think really thinking about bidirectional partnerships and what these could look like. Obviously, we've talked a bit more about why they're so important. And so I think remembering oftentimes that low resource often refers to human resources as well. And so oftentimes our local counterparts are probably working twice as many jobs and doing a lot of things. And so balance, not that we don't balance a lot oftentimes in our own work, but I think it's just keeping in mind that, you know, the numbers and are purely against them in terms of, like, you know, how many people you have working on certain things. So this is, as I mentioned, Pendo, or Dr. Upendo George. She was one of the first female emergency medicine physicians in Tanzania. She was the head of the pediatric emergency department at Muhimbili, and a dear friend and colleague who worked closely with me to lead this curriculum development effort for AFEM for over 3 years. And because of her efforts and connections, that's how we got to be able to hold this pilot of the Tier 1 curriculum at Muhimbili. And she was supposed to be actually the lead instructor, not Kilalo originally. However, as soon as I arrived into DAR to launch this, obviously, she calls me and she's like, I've been told by the hospital that I need to oversee, they were starting a new EMS training program. And she was like, I've been told that I need to oversee this EMS training program. And so she was like, I can't teach. I won't be able to teach during the sessions. So, and obviously she was very dismayed by this. But this is the reality, right? We all get pulled into different directions, and this is where she was told she needed to be. Luckily, we were able to pivot Kilalo to be able to teach. But it's a common example of sort of why, we need to be able, true partners sort of recognize a lot of these limitations. And it was sort of one of those things where we're like, that sucks, but we got to roll with it, right? Let's find something else. Let's see how we can pivot, and really being flexible enough to kind of find solutions. Unfortunately, Pendo passed away suddenly and unexpectedly last November. And I really can't express what a loss this was for all of us, but her legacy still lives on and all the lives that she's touched and she continues to touch. So talking a little bit more about partnerships. So as I mentioned, how do we make these partnerships truly bidirectional partnerships, right? And I think, obviously making sure our priorities align, as I've already said, is something that can really get us there. But this can be a little tricky sometimes. And I just wanted to point out that it's oftentimes not as straightforward as we'd always like to think. We all want to be polite when someone offers us, we come over and say, oh, look, there's this new curriculum, let's launch it. And we all want to be polite and say, yeah, sure, I'd love it. I'd love to do this. But sometimes these power dynamics can really prevent people from feeling empowered, to be honest. So I think really trying to dig down to these and making sure that priorities really are aligned. And therefore, when something goes awry, like Pendo got pulled away and she had to do something else, then we turned to the emergency department leadership in the hospital. And we said, can you help us find someone else? And they did. So I think the will has to be there to kind of, and that only happened because, this was something that we all were invested in and found to be important. Other things to think about: plan ahead, but stay flexible. Enough said. You guys have all done work. You know exactly what I mean there. And then finally, I just wanted to put in a plug for just recognizing your privilege and using your superpowers, really using your superpowers to advocate for your partners. And I think, and I guess, obviously I'm speaking from the perspective of someone working in a high resource setting with partners in a lower resource setting. So what are your superpowers? So access, right? So like I mentioned, when we traveled to Tanzania and Liberia, we brought training supplies and materials with us. And I think being able to leave all those behind to allow people and giving people the resources that they need to be able to continue to train even when you're not there. So it's not something that you are pushing forward, right? Again, this is something that we all, yeah. So it's, oh, thank you, Maron. I'm reading your message about, training the trainer and really making sure that people can continue this training once you're gone, right? It's not about, it doesn't all come from you and your group. It's something that, we really want people to take in and pass along. And then, and as I mentioned, making the curriculum freely and publicly available through AFEM once it's done. And then for those of us who are in academia and have received a lot of research and scholarly training, I think we do have a responsibility to share that, right? And to share not just our skills in scholarship and research, but also, the recognition. So including your local partners as authors in anything that you publish or present, having, working with them to be the presenter, to be the writer, those are all ways that we can sort of use our superpowers to develop in other ways in our partnerships. Because these really are partnerships. It's not just projects, right? These are partnerships. So the grants that we are fortunate enough to be awarded to support these these efforts paid for the time for all of our Tanzanian and Liberian instructors, our data collectors, and any associated resources. So that's another way you can kind of support. This is the manuscript that we published with all our partners. This is just on the Tanzanian one. We're still working on the Liberian one. Oh, COVID. And then finally, I just want to leave a few minutes for more questions. Just wanted to give some of my thoughts about building a career in global health. So, and these are some of these things I sort of touched on before. But one is, and I call this like be there. So for those of us some of you are trainees working in, you're being trained through UCSF or other high resource places, and you want to work in these global communities. There are so many different global health communities, and they all have different foci and different places that they emphasize their work on it, and different values and how they approach their work. And so I think for you, it's sort of figuring out where is it that you kind of want to work and how you want to work, and then finding people who are like-minded and sort of and joining them, like be there, network, really get to know these people. So for me, a lot of the work that, as I mentioned, I had wanted to do was around medical education and also in systems building. And so I was able, so what I did was I went, I am in both pediatrics and in emergency medicine. And so for me, I had our American groups like AAP and ASAP and SAEM, who are, I know a lot of letters, but these are all like sort of the national conferences for our groups within the US. And then there was AFSEM and there was AFAM. And then obviously the AFSEM is the African Conference for Emergency Medicine, held, I think it's every 2 years. And that was another way to kind of be there. I know with COVID, it's a little more difficult to travel right now and actually be there. But a lot of these are getting, like the conference that was supposed to be in Kenya was actually was switched to virtual. So there are ways that you can still participate, maybe not in the same kind of ways, but I would encourage you to sort of be there. And for those of you who are doing this work already, also feel free to chime in with your thoughts as well. These are just sort of my thoughts. And then the other thing is do it. So I think if you're starting out in your career, finding global health mentors is really helpful. I've highlighted here some of my mentors. So you'll recognize Pendo in the picture above. She's definitely one of my mentors. And then in the picture below on the right, that's Andy Tenner. She's one of our emergency medicine faculty and global health faculty, and she's also a mentor, a very close mentor and friend of mine. So finding global health mentors, again, who are doing similar work to what you're interested in and who approach it in a similar way with similar values as you, I think is really important. And then, and get your hands dirty, really try to get involved in some projects. But again, and I said this before and I've outlined it here, but I think not just getting involved in the projects and building the projects, but seeing as this also is building and investing in relationships. You'll be surprised. It's a small world in global, well, it's small and it's big in global health. And so I think I think if you really invest in these relationships, it also sets you up for more effective projects and kind of making the difference that you want to make in whatever setting it might be. But I will say, we're all busy. I know trainees have a lot going on. So, if you do sign up with a mentor to take on a project, I would just encourage you to just do what you say you're going to do. Sometimes it's hard to predict, like COVID kind of can derail things. But I think just making sure that you follow through and whatever that you're working on with someone is always going to be a benefit. So, all right, so I'm going to stop there. Yes, that was my last slide. So, and I can take more questions.
Great.
Dr. Chen. Oh, go ahead.
No, please, you go ahead.
I'm Elizabeth Sanso. I'm a former UCSF med student. So hello.
Hi.
Great talk. I really enjoyed the talk. Thank you so much. I love that you ended with that concept of mentorship. I think mentorship is so important. And I wonder, you mentioned that you have mentors, international mentors, and you showed us pictures. Do you have a formal mentorship program with your international partner sites. So like daily, they can WhatsApp you, or weekly or monthly, and establishing almost like that PEC or that pediatric emergency care coordinator, but at your sites, to kind of be responsible for that on the ground learning. And then they have the mentor to reach out to you and vice versa.
Yeah, that's a great question. And thank you for bringing that up. I think we do have, we definitely have WhatsApp groups for sure. It's very active. There's a lot of WhatsApping. We have some based on, say, region, and then also based, so like AFEM has an East Africa group. We also have kind of a general AFEM med ed group. And then we also have, and then like I have my WhatsApps with like, say, the group at Muhimbili or the group at JFK. And so, but it is not as formalized sort of as you've presented it. It's more of an informal, we're around, reach out if you need anything kind of thing. So I do think it's an interesting idea. I do think, perhaps putting a little more structure around it and saying, we're kind of having check-ins and whatnot, I think is a good thought behind it. I will say it's a difficult balance, I think, because you're trying not to overload your partners too, and saying, we need to talk and whatever. So I think, but that being said, as we all know, you get busy with stuff and you forget. So I think also having those regular check-ins is a good idea. Yeah. But I think I totally agree with you. I think having that open line of communication with WhatsApp has been amazing. Like just really being able to talk to people and at any time, day or night. I mean, we all recognize that no one's going to answer if it's their middle of the night, but having that is also important.
Thank you.
Yeah. Any other questions? And anything at all, not even anything I talked about.
Thank you so much, Carol. I do want to still keep the floor open for questions. In particular, I know that there were some folks who had joined from sub-Saharan Africa. So would love to elevate some of those voices and to see if you have thoughts on the state of pediatric emergency care, pediatric critical care there, and to some of Carol's comments about partnerships and how that's looking for you.
Hi, so I'm Charlene from Ghana in West Africa, for those who do not know where that is. We don't have a formal pediatric emergency medicine training program yet. It started a few years back for the adult emergency care. We're yet to start a pediatric emergency training program, even for doctors. So it's not yet a field. Usually the training and nursing follows training for medical doctors in terms of the subspecialties. So that hasn't started yet, but it's nice to see that there's a lot of work going on in the eastern parts of Africa. I'm hoping that, listening to this got me thinking that maybe, because sometimes it's difficult to start when you don't have faculty on ground. And that's one of our challenges. We need the core faculty to be able to actually start training. So maybe with this whole global health partnership initiatives, we can spread beyond just the eastern parts of Africa and start coming a little western. I think Southern Africa seems to have a stronger training system compared to the eastern and then the western parts. So there's still lots of gaps even in the western parts of Africa. So maybe we can look at partnering down this way as well. Thank you.
Yeah, thank you for those comments. I totally agree. Having the faculty there it's hard. Again, getting all the resources lined up to be able to launch a lot of these things. But I think AFEM is a great resource in case you guys are interested in reaching out to them. And we've, like I said, we've made already the Tier 1 curriculum available on their website. I know some places have been able to take that and and develop different things from it, small things and bigger things from it. And then I think the West African chapter of AFEM definitely has, I don't know if you're already involved with them, but they definitely have a group that kind of discusses how to best roll out stuff. So just some thoughts if those are helpful.
Great, thanks.
Excellent. Well, it's a little bit past 9, so I think we're going to have to leave it there. But thank you again so much, Carol, for both describing your work and then your process and then your own personal journey. So really appreciate all of that. For those interested, as Carol was alluding to, our next session, I believe it's at 10:15 West Coast time, sorry, 9:15 West Coast time, so in about 15 minutes or so, with Dr. Nick Glum, who's one of Carol's colleagues and does work on curriculum development also, I think in Botswana. And then we pasted the eval link in the chat. So please, if you have a moment, go ahead and fill that out too. And then with that, we'll close unless you have any final comments, Carol. Thank you again.
No, you're very welcome. Now, I was just going to say, you guys feel free to reach out to me if you have any other questions you think of later, or if you're, if there's partnerships, that you think could be beneficial for you or for any of the work that we do. I'm going to put my email in the chat. And I'm also going to put the AFEM website in the chat so that you guys can have that, and totally feel free to reach out anytime. It was really great speaking with you.